right, we will go ahead and get started. Good afternoon, everyone. Again, thank you so much for joining us today in what is probably your lunch hour. My name is Laura Krizwicki, and I am a program director here at CFPIC. We're glad to have you with us for another one of our monthly Lunch and Learn sessions. I'm especially excited about today's discussion around the enhanced care management workflow. This document was developed in direct response to county requests, incorporating your input on how to best navigate ECM referrals. We recognize that this is a nuanced process where a family is at in their journey, whether it's prevention, removal, ongoing services, can greatly affect how ECM referrals are approached. And this guide is exactly that. It's a guide and a resource. It's not intended to override any county-specific policies that are in place. Instead, it offers best practices and serves as a starting point for local discussions to strengthen your approach to ECM implementation. Before we dive in, I just want to take a moment to thank some of our key partners who've made today possible. A big thank you to CWDA for their ongoing sponsorship and support of this work. We're also grateful for the collaboration from CDSS and DHCS, and also their providing input and review to today's presentation. A couple of quick housekeeping notes before we get started. Today's session is being recorded and will be available on the CFPAC website, where you can also find past Lunch and Learn sessions and a range of helpful tools and resources. Peter is just dropping that in the chat right now. And at the end of the session, we'll share a short survey. We'd really appreciate it if you could take a moment to fill it out. Your feedback continues to help us shape future sessions. And so I will turn it over to our presenters, the other facilitators, to introduce themselves, and I will start with Baljeet.
Great, thank you, Laura. Good afternoon, everyone. Baljeet Handon. I'm a CalAIM consultant. Have been working in this space now, well, at least nearly going on 2 years. Glad that we're able to provide this guide to you guys and kind of walk through it. And I'm going to pass it on to Corey.
Good afternoon, Corey Allen here. Joined the CFPIC team in the spring. I'm a recent retiree from county government with my last role as a Health and Human Services Agency Director in Calaveras. So I'm really excited to join this conversation today. And with that, I will pass it on to Derek.
Thanks so much, Corey. Good afternoon, everyone. My name is Derek Swama. I am the Prevention Program Director with CFPIC, and specifically working on a lot of the efforts. And so happy to see many names on here involved in comprehensive prevention planning, but working within the Family First Prevention Services space. And so work really closely with our capacity building system integration partners at CFPIC. And just so grateful to be here to talk about the alignment of ECM with prevention. So I'll turn it back to, I think, Laura, right?
No, me.
Or Baljeet, I'm sorry.
Yeah, no worries. All right, so if you can just give me a moment as I get the presentation up here. I recently got quite technically savvy here at home and have a huge double screen, and so I'm learning how to navigate both of them here. So 1 second. All right. And hopefully everyone can see the PowerPoint and not anything else at this point. I'm also going to pin all of our presenters really quickly so that you just see us. Okay, 1 second, I think. That should be it. Corey, I'm going to pin Corey. Okay. All right, so like Laura mentioned, this is our lunch and learn for the ECM workflow guide, and it should have been dropped into the chat. Also, we have dropped the slide deck for today's presentation. This is about how to implement the referral flow for ECM in your county, and like Laura mentioned, this is, we kind of took a approach of this is a statewide implementation, but really look at how you would do this for your own particular county. And so this guide is very adaptable to your local policies and procedures and local practices, and we'll highlight some of those opportunities where you may want to insert local policy and practice into this. So as you know, ECM is a benefit and service under Medi-Cal managed care plans. It's been here for a couple of years now. Child welfare is the population of focus. The state has prioritized services for children, youth, and families that you serve. And so we really want to highlight getting these services to those children, youth, and families that would benefit from these. So this affects not only children and youth currently in foster care, but also those who are exited or have exited within the last 12 months, youth that are aging out, our finalized adoptions, guardianships, and family maintenance cases. So this isn't just policy. This is about really connecting families to comprehensive health and social services they need to succeed. All right, so just to kind of give you an overview of the document, I believe it's 20 plus pages long, maybe close to 30. I can't remember the final number. Like Laura mentioned, this has been a collaboration with many partners. And we've been working on this behind the scenes, trying to get this ready for you guys. But I want to start with the eligibility of who qualifies for ECM. We do list this in the guide, but again, it's for youth, children and youth who are under 21 and currently in foster care in California. And that includes, youth that are placed here out of state. Youth who are under 21 who receive foster care within the last 12 months, aged out of foster care up to 26, youth under 18 in the AAP program, and then last, any families that were part of the FM caseloads in your counties, either currently or within the last 12 months. So this guide is created to help you engage with your MCPs, with your ECM providers in your county, and to really build those partnerships of identifying children, youth, and families that would benefit from this service so that you make those appropriate referrals, and then they can be a partner at the table to help you as you serve those families, children, and youth. So ECM addresses all areas of health and well-being, including primary care, specialty care, dental, mental health, substance use, long-term services, and supports. Now, in the guide, we do mention, being aware of managed care plans and what are the options in your county. And so we're going to kind of talk a little bit about that as we go through the presentation. So the way that we structured the guide, we really looked at unique, kind of looking at it from how children and youth kind of flow through the child welfare system. And so the guide starts with the new cases pathway from initial removal through the CFT to dispositional hearing. We also then dedicated time to the family maintenance process. Existing cases, how would you look at current caseloads that you have and identifying children and youth that would benefit from ECM? And then we also looked at the prevention pathway and how would you build ECM and the referral process into your ever-evolving prevention landscape that is happening across the state. And so Derek is going to talk about that when we get to those slides. We also, with Corey's support, really kind of looked at this from the tribal angle as well. And so Corey is going to lift up some of that as we get to those items in today's presentation. Again, I really want to highlight that we kind of looked at this from a statewide process and really look at, do you have local policies, procedures, practices that maybe are a little bit different, and you can adapt this guide to your local policy and practice. And just last critical point here, this guide is organized by how your work typically flows and not by agency silos. And so you know, again, it's really looking at building those partnerships with these new entities that are coming into the child welfare landscape, such as the managed care plans, ECM providers, but also lifting up other traditional partners that you've always worked with, like your behavioral health partnerships, your public health partnerships, and how can you incorporate that into this guide for your local practice. So the document identifies responsibilities for county staff, which we included as county child welfare social workers. And you may have others at your agency that also help manage caseloads. When I've worked in other counties, we had other positions that were helping. And so maybe you want to add some of that to the guide for your local practice. We included eligibility workers in this as well, just because they play critical roles in the beginning when children come into care, and how they can help support this work as well. And then we also identified public health nurses in this as well. In some counties, public health health nurses, in every county, public health nurses play a pivotal role when children come into care. But in some counties, public health nurses also work in ER referrals, or maybe on your FM caseloads, or maybe you're going to identify that they're going to play a role in the prevention work as well. And so again, adapting the guide based on your local practices. We also introduce some of these healthcare partners in the guide, which includes the managed care plan child welfare liaison and how they can assist in this work. We want to lift up that the managed care plans also have tribal liaisons that they have to staff, and how they can help when you are working with a child or youth or family that has tribal affiliation. And then obviously the ECM providers that are going to be part of this pivotal work, especially if you're making referrals to ECM. And then we also want to make sure that we're staying true to the ICPM framework. And we do have a slide on that later, and Corey's going to talk about that. But making sure that we're lifting up family voice and choice in this, and recognizing that our team also includes resource families, birth families, recognizing the voice of youth and non-minor dependents, and again, tribal and equal representatives that are also part of the work that you do. And then, you know, others included, especially if you're going to incorporate this into your prevention pathways, all the CBOs that are also part of that, that maybe are not coming on as ECM providers, but they are going to be part of your prevention pathway, and including them in this as well. All right, so just moving on to the new cases, and this starts on page 9 of the guide. We have a table for each particular case that we're talking about, or particular area of child welfare. And so we start with initial removal and what that would look like in the guide. And so really it's around this first couple of steps around what is the Medi-Cal status. And so the guide really helps you to look at checking what the Medi-Cal status is, understanding if you're a COS or single plan county, typically children and youth or any actually Medi-Cal member in that county is automatically enrolled into the managed care plan of choice in that county. Now, if you're not a COS or single plan county, you then have to help identify what are the options for managed care plans in your county. And so some of you have 2 or more plans that you're navigating in your county. And again, how do those decisions get made? And so we've included in the guide some of those steps and who to include in those decisions. Let's see, again, lifting up when it's appropriate in initial removals, parents' voice in this, both parents' voice, especially if this case is going to move into FR, making sure that we're not choosing plans that maybe are counter to what the family has when they're all together, and recognizing that continuity of care is also important. Children were in managed care plans before they came into foster care. And so maybe trying to think about how to make sure that they continue to remain in the same plan so that they can continue to see their same providers, and especially if they had specialty providers before they came into care. So the guide kind of walks you through all of those steps. And I'm going to pass it on to Corey to talk about how to have those discussions through the CFT process.
Thank you, Baljeet. So we already, within our county systems, our partnerships, have the child and family team pretty locked in. It's something we've been doing for some time. And what we're going to do here is just walk you through expanding your child and family team partnerships to include those that are helping families and their tribal representatives when needed to identify the best enhanced care management system and managed care plan. So before your CFT meeting, of course, as we've done for some time now, we'll have that CANS assessment is initiated. We're going to be identifying missing health information, collecting that on the JV 225 form. And we're going to review either the fee-for-service versus the managed care plan options that your youth and family that you're working with is eligible to. So with that, you're going to have some counties that don't have multiple plans. And but for those where there's some options, we want to make sure that that child and family team is an opportunity to get the voice of your child, your parents, your tribal representative, and of course, your professionals that wrap around the family. During the child and family team, you're going to be working through the issue about the enhanced care management referral and enrollment. You're also going to use that time to fully engage with the family on their own needs assessment from their perspective. And for those that have any tribal associations, we're going to make sure that we've invited and engaged the tribal liaison, of course, with the family's input. But we just want to make sure that we're not losing sight of those elements that are already so well intact in our processes by adding ECM conversations to the team. Of course, then we're going to complete the CANs through facilitated effort, and we're going to develop an action plan, and it's going to include care coordination. One critical piece is going to be to get those final consents for services to make sure that we have the proper authorities and understanding from the family about what those mean, including the sharing of information. We then, of course, want to make sure that we set an ongoing schedule to meet the needs of this particular child and family in order to make sure that all those partners have it scheduled and it's not something that just is surprising to them each and every rotation of those meetings, which could be every 30 days, could be 60, 90, depending on the particulars of this child and family. After your child and family team meeting, you're going to have your enhanced care management care plan updates. These are going to be updated based on the outcomes of your meeting, the conversations and agreements that were made. And you'll want to make sure that we have ongoing partnership and communication between the ECM providers, the social workers, public health nurse, and any other person or entity that you've established within your partnerships. Do we want to go to the next slide?
Thank you, Corey, for that. All right, so I'm going to move on to family maintenance. So we have a table for how to navigate ECM and MCP choice on our family maintenance cases. So one thing to remember is that obviously in family maintenance cases, the parents still have a voice and right to decide about what managed care plan they want to be enrolled in. And so in the guide, we've given you tips and how to navigate that with the family. Now, again, if they're in a single plan or a county organized health system with just one plan, that decision is going to be made automatically for them. And so this is probably more for counties where you have more than two plans to choose from. Having the conversation with the family in regards to, are they happy with their plan? Are they getting their needs met for themselves as parents, but also for their children? And if they're not happy, maybe helping them understand that they can make decisions to change the plan if there is another plan available to them. And so the guide kind of helps you walk through that. Now, like I mentioned in the beginning, if your public health nurses are involved in FM cases, this is an opportunity that you may want to use the guide and add some of that partnership there. If they're not, then that I would remove that language that we have in the guide for public health nurse involvement. So for FM cases, the decision around ECM needs to include the family. And like Corey said, you can have those conversations through the CFT process. If you are holding CFTs for your FM cases as well. And I know, county by county, that's a decision that's made locally. If you're going to include the CFT process on FM cases as well, if not, that's fine. You can have that conversation with the family directly. If you are, again, utilizing the CFT process for those conversations, but making sure that you have family consent before you make those referrals to ECM. ECM is a benefit, but it's not a mandatory benefit. And so one of the first steps that ECM providers have to do when they are given a referral for a child, a youth, a parent, an adult for ECM is that they actually have to do outreach and engagement themselves. Us saying that the family or the child, the youth is open to these services is enough for them to engage with them, but they actually have to get agreement from that person directly. And so they will do that themselves. They are going to help the family understand what they're enrolling in and also understand that this isn't mandatory, it's a voluntary benefit and what they would get from it and what's required as part of the benefit, because they now have another provider that could be coming out to the home, meeting with them. They would have a care plan. They would have additional services and supports that the ECM provider may decide that the family would benefit from, again, with their consent, engage and enroll them in any of the 14 community supports. Like Corey said, having tribal representation and representatives involved, if we do have tribal affiliation with a family, is going to be important at this, but again, based on family voice and choice. One thing I do want to highlight, and I talk about this when I do ECM trainings at the local level, is if you think a family, a child or youth is appropriate for an ECM referral, have the conversation, and if they agree, make the referral. Because if ECM becomes involved and a provider becomes involved, one of the things that they are asked to do by the state and by the managed care plan is assess that individual for any of the 14 community supports that are appropriate. So they then make those additional referrals and connections. They then stay on top of making sure that the community supports providers are doing what they need to. And so that's one thing that an ECM provider could do for child welfare that maybe then child welfare doesn't need to worry about themselves. And you would just monitor this through, your monitoring processes, either through CFTs or as you engage with them to get follow-ups on how ECM and the work there is going. All right, I'm going to turn it over to Derek to talk about the prevention pathways with this.
Great. Thanks so much, Belgi. And I just wanted to start out by giving a little bit of context to when we talk about the prevention pathway, and when we reference it here, it's really for the purpose of referring to the community pathway. So as you'll see it document or outlined in the guide that you've been provided, but really the purpose is connecting to that community pathway. And the community pathway, just as a reminder to folks, is that avenue in which families can receive the services, the supports within the community and through no wrong door. And so this includes the more formal community pathway in which a family might be eligible for 40 funded prevention services, or it could be the community pathway at large to make sure that family has the ease of access, excuse me, to any service and or support they might be seeking or we need. And so for the purposes here, as I mentioned, we're talking about these circumstances in which a family has no interactions with the child welfare agency, but may be working with a community provider. For those that may be receiving prevention services but have an open case, so maybe regarding that 4E agency pathway within the FFPS Family First Prevention Services Program, really in those circumstances, you'd want to refer back to the process that Belgi and Corey had outlined, especially with family maintenance cases and so forth. But here I'm going to talk a little bit about the steps through which and the roles and activities for community providers versus the ECM provider. So as you'll see here, when that family is working with a provider and really suggested upon intake, the community provider really can start talking with the family about their Medi-Cal status and explain some of those benefits that come with Medi-Cal. So for families that are not enrolled in Medi-Cal, it's really highly encouraged that as part of the case management practice, or even when providing that immediate support, that community provider connect the family with the necessary resources to enroll or get support with enrolling. So that provider may also be able to be the one assisting that family in getting enrolling and applying for the benefits. And then when identifying the Medi-Cal status and managed care plan enrollment, there's really an opportunity there to then talk about ECM services, especially in circumstances where a family may be eligible for ECM services. So referring back to the eligibility criteria and noticing that there's also some of this overlap in eligibility criteria that might be included within ECM services and the Family First Prevention Services program. But after introducing ECM services and the family identifies that they might be interested in being connected with those supports, providers, can then refer through a universal referral form. But also note that when introducing the ECM services and referring the family to those services, it's really crucial and important to ensure that the community provider that they're well aware of and trained on and clearly aware of both the ECM eligibility and the referral process. So this is also an opportunity to train those community providers and partners to be able to create a seamless referral system, either through that training of how the referral might operate, but also creating that partnership and bridging with the managed care plan and looping them in through that process as well. But once the services are set up and established, it's then important for the community provider that may be providing ongoing support services and case management to then coordinate the care and the services with the ECM provider. So especially when we think back to family well-being plans or what is otherwise known as prevention plans within the Family First Prevention Services program, This should really be an essential part of their plan, of that family well-being plan, and really coordination with the ECM provider to ensure that there's no duplicative supports and services being provided, and to ensure that those services and supports are consistent. And so I just want to acknowledge that many community providers probably may have some of these steps already embedded within their process. It may just involve adapting them to ensure that families are connected with that specific ECM service or support, and specifically and going the next step to make sure that there's coordination occurring between the two providers. The coordination ultimately comes down to the role for the community providers and the ECM providers, both of those entities. And it's really highly encouraged that ECM providers are aware of the eligibility, services, and planning within the Family First Prevention Services program to, again, increase that consistency between coordination and services. And then lastly, I just want to acknowledge that within each of these areas and these roles and activities, it's really encouraged that county comprehensive prevention planning leads and their teams meet with their CPP providers to orient them to ECM services, and the MOU that's established between them and the local managed care plans. And so this might include sharing all of these steps that case management providers can engage in to refer to ECM services when they might be eligible. But it's also really encouraged that these activities, steps, and coordination efforts really be embedded within the community-based providers within the contracting process with community-based providers. So maybe outlining some of these specific activities, what some of those expectations might be with coordination with ECM providers as possible. And really, so I think just placing that huge emphasis on this coordination of care within both the community supports that might be provided through the provider, but also ECM services. And so I just wanted to leave a resource as well, that back on May 29th, with our great partner, Gretchen Schroeder, we held at CFPIC a webinar called The Role of CBOs in CalAIM, where we talk about ECM. We hear from a couple of CBO providers on how they're coordinating ECM services and supports, among other CalAIM supports. And so I am going to drop that recording. It's a link to our Watch and Learn page at CFPIC, but you should see that at the top to reference in case you wanted to explore it a bit more.
Thank you, Derek. We'll have plenty of time at the end for questions, because we're kind of going through the slides pretty well here, so we'll have plenty of time at the end. Now, also in the guide, we did kind of hold a place for special circumstances, which includes out of county placements, and just some of the issues that we have discovered through this process and the learning that we've done in the last 2 years, of understanding what does it actually look like when children are placed out of county, and managed care plans look different county by county. And so this wasn't really to get into the issues around that when youth move from county to county, but kind of looking at it if they were receiving ECM services in one county and then they got placed in another county, what are some of the conversations that then now need to happen? And one of the biggest conversations is, if the child still needs ECM services, can the current provider continue to provide those services in the next county? Or because of distance, or maybe they're not contracted in the next county, would it be better to engage them with a new provider? Now, one thing to bear in mind is that even if they're not contracted in the next county, continuity of care kicks in, and ECM is seen one of those benefits that is under the continuity of care protections. And so the next managed care plan would have to work with that ECM provider to get them contracted, but also to make sure that services are not impacted as they're going through this contracting process. And so as much as possible, advanced planning is important for this. If you know that a youth is going to move and be placed out of county, and engaging the ECM provider in that conversation to obviously determine if they are going to be able to continue to serve that youth. Part of ECM does allow for virtual and telehealth when it's appropriate, but I think we know that in person actually works a lot better for our population. And so if the distance is too great, it probably will not benefit the child or youth or family to continue to receive ECM from that provider. And so helping set up a new provider, you can utilize the current ECM provider to help with that. You could definitely reach out to the managed care plan child welfare liaison to help identify a new provider, and then do that warm handoff as well, and help through that process, right? The other area that is enclosed in the guide is case closures. We as child welfare agencies are ready to close our case, but the child, the youth, or the family still needs ECM services. And receiving ECM services are not dependent on us being involved. There's 9 populations of focus under ECM that qualify for these services. Child welfare is just one of those populations of focus, and most of our children, youth, and families would qualify under one or more populations of focus. And so there is an option under the child welfare population of focus, which says that they receive services from child welfare in the last 12 months, so they would definitely continue to qualify, or they would qualify under another population of focus. And so in the guide, we do have information about how to do those kind of, case closures when child welfare is going to drop out of the picture, but ECM needs to continue. And then in the guide, we have existing cases and how to look at existing cases that your staff are already working on in your FR caseload. That's already, quite involved in FR, your existing FM cases, your existing adoption, PP caseloads, all of those other caseloads, your non-minor dependent caseloads. How do you assess those for ECM and get those referrals made? So we do have information in the guide about that. And another thing to keep in mind is maybe today it's the child or the youth or the family is not open to ECM, but maybe a routine conversation about ECM if you feel there is a need for the benefit, and keeping that in the forefront of maybe, the family is feeling overwhelmed right now with child welfare being involved in all the other providers that you have involved, and maybe right now isn't the best time, but maybe having part of the flow is that constant or ongoing conversation of maybe not now, but maybe later they would be open to it. Let's see. I'm going to hand it back to Corey for key implementation principles.
Thank you so much, Baljeet. So what this slide is going to do is it's simply going to take us from the slide I gave you on the child and family team and just restate the importance of the work that we're doing with this little adjustment in handling the enhanced care management and working with our managed care plan partners, and always doing so from an integrated core practice model framework. So I didn't mention it well, so I'm going to state it here again on the CFT slide. You're going to have additional members, and in the teaming that is part of our system of care in that child and family team, you're now going to have potentially a managed care plan tribal representative and a managed care foster youth representative. So you have additional voices in there. When we add voices and we add sort of expand that team, I just wanted to make sure that we remember to be culturally relevant, to have that youth and family voice be the driver in their own service planning. You want to make sure that the consents that they're giving are well understood. that the releases that are necessary for information sharing are conducted timely and sensitive to the way in which the family operates, the way in which they receive information. And some of the success factors that we sort of identify here is that verbal consent is sufficient in order to make the referral for enhanced care management to the managed care plan. It's a first step. Then that managed care plan representative will finalize the signatures and things to make sure that their relationship and information processes are sound. And that being said, the independent enhanced care management outreach is done intentionally. And what it does is it gives a nice, warm, health-focused connection to that family that doesn't get colored by any child welfare engagement or involvement. The communication, it's so critical that it be ongoing, that it's regular between your social worker, your public health nurse, and now a variety of ECM providers and liaisons. We talked about the CFT meeting, the integration and the coordination of that care, and that we're really just adding just a few more elements in there. But what this is going to do under this ICPM framework is provide opportunity for rich conversations around where this family can best be met in a broader network of services. And you want to make sure that it's all documented. So it's going to be documented well in your case plans, obviously in your court reports. So here on the slide, you'll notice we've got some resources for contacts with your healthcare options, your Medi-Cal ombudsman, and your managed care plan child welfare services liaisons. There's an email there. We are giving you a link to this particular PowerPoint, so you'll have that information at your fingertips. With that, let me hand it back to Belgique.
Thank you. I do want to share that, and we'll send other links in the email. So CDSS can get you information about who your MCP child welfare liaison is, and they've created a whole web page dedicated to CalAIM. And so we'll provide you those links in the email that we'll send out, and then also links to the DHCS CalAIM dedicated web pages. It's a lot of information. It can be a little bit overwhelming, but we'll include those links as well in the email. So next steps. First and foremost, one of the first things I want to say is we've done a very quick presentation of the guide. We didn't even bring the guide up. And so if you want additional technical assistance and individual TA around the guide and how to make it work in your county, we are here for that. And we'll put out emails in the chat so you can reach out to myself. You can reach out to Laura or Peter from CFPIC or Corey, and then definitely reach out to Derek if you're looking at how to make this work in your prevention work that you're doing to kind of look at how to, include this in that. So as it says on the screen here, it's about maybe looking at your workflows and how do you assess for services and supports now, and how do you include ECM into that? And so this is a guide dedicated to ECM, but maybe you have a policy and procedure that looks at any referral. And so how do you adopt this guide into that policy and procedure? Look at your current caseloads and where are good times that this conversation should happen on existing cases. Most of you have been working with your managed care plans now since the state has an expectation of an MOU between child welfare and the managed care plans. Now, it is a mandate on the managed care plan. It is not a mandate on the child welfare departments, but we do recognize that it is an opportunity to kind of leverage resources that the managed care plans have at their disposal. And so we are highly recommending that counties, if you haven't executed your MOU, to continue to work through those negotiations and maybe some of those pain points. Reach out to us. Corey and I will be reaching out to counties to kind of see where you are in the execution and provide some tips and strategies of how to move that forward. Training. So the guide does not train your staff. I want to make that clear. The guide does not train your staff on what ECM is and what is this benefit about. It doesn't train them on what's a managed care plan. When I came into child welfare 30 years ago, I just knew Medi-Cal is straight Medi-Cal. I've learned so much more now through my CalAIM learning that Medi-Cal is so much more than just a straight Medi-Cal or fee-for-service. And so Laura's going to mention this later, but there is a plan to help counties train their staff, and it's something that we've been working on behind the scenes. A big part of this is building those relationships, as it mentions here on this slide, partnering with your managed care plan, child welfare liaisons, partnering with your ECM providers, looking at opportunities to strengthen current partnerships through your AB 2083 work. And, that's part of the MOU. We've lifted up some of that in the MOU for you guys, but really looking at how can you strengthen some of these partnerships. And then looking at the long-term goals. Why do we need to engage in this, right? We know that the state is really looking for all members of the 15 million that are part of Medi-Cal in California to be part of a managed care plan, to get their services and supports, oversight, monitoring through a managed care plan. And so how do you, in your departments, leverage this for the children, youth, and families that you serve? I just want to share that I attended a conference yesterday in LA, and it was actually for another project that I'm working on with DV providers, but there was several managed care plans there, and one in particular gave a presentation, and it was a great presentation around what this particular plan has done in their county, and they're only in one county, to really invest back in the community. And so the plans have resources at their disposal. They have dollars at their disposal to really invest in the community, to lift up vulnerable populations, because they recognize when you lift up a community and you better them in their social needs, you also then improve their healthcare outcomes as well. And so, again, just making a plug to continue to work through those MOU challenges that you might be facing, and reach out to us if you're looking for some guidance and assistance there. Last, we know with any implementation, it's not perfect on day one. We created this guide without thought and process. And what I've learned as I'm doing staff trainings, I don't know if anyone's here from Sacramento County, but in the month of May, I trained all of Sacramento County's child welfare staff. And I also trained in June all of their adult and aging program staff. And I got a fresh perspective of what actually does this look like on the ground floor. And so when you go through this guide and you see things that maybe we missed or things that we didn't think about, please let us know, because we want to continue to make this a usable document that will work for all of you. And so we kind of see it as a living document that we can continue to update and make better. I'm going to see if Corey or Derek have any last comments, and then we'll turn it over to Laura for last statements.
I do not have any final comments. I'm going to pass it to you, Derek.
Yeah, I think it was we covered it all, but happy if folks have other questions beyond this regarding the prevention realm, feel free to reach out to me as well. Happy to support.
And maybe we can see if, and I'm going to stop sharing my screen for now so that we can see everyone. I'm going to stop pinning. Um, and,
We have our first question in the chat, Miss Beljeet.
oh, okay.
So I'll read it to Derek. Thinking about prevention pathway, if a family qualifies for Medi-Cal, does that exclude them from FFPS funding because of the requirement of payer of last resort?
Yeah, so Candace, I would say not necessarily that they would, for simply qualifying for Medi-Cal, that they would be um, excluded from any 4E funded prevention service. With regards to the payer of last resort, I know the state is still developing guidance on what evidence-based practices are going to be reimbursable, which components of those are going to be reimbursable from Medi-Cal. That'll help then inform the payer of last resort. And I know there was a letter released and I think it was back in May for that payer of last resort. I'll drop that in the chat. But I think that that's something to still determine. I think there's going to be those ECM services that are going to be provided through Medi-Cal and Cal-AIM that would not necessarily, unless it is an evidence-based practice that would coincide with FFPS funding and requirements, then that would be where you would want to consider this payer of last resort, right? Guidance. But ultimately, if they're receiving an ECM service that would not be even eligible for 4E funded prevention services, then that wouldn't really have as much of an impact on what they might be able to get reimbursed for maybe that evidence-based program they're offering through the Family First Prevention Services program. I hope that clarifies a little bit, but I'll drop the chat in the chat the link to the payer of last resort guidance as well.
Great, thank you. And I do see another question. What if families have their private health insurance without Medi-Cal? Would they benefit? So good point, because I did want to share that with the changes that are coming down from the federal administration around Medicaid. California's Medi-Cal program is Medicaid, right? So some of our families may find that they now have a share of cost based on income levels. And so in order to get the benefits of Cal-AIM and ECM benefits, a member has to be in a managed care plan Medi-Cal. And so if they have private insurance, they wouldn't benefit from this. Now, maybe the ECM provider, the county has a contract with the ECM provider, because a lot of the ECM providers for child welfare are providers that you use for other services. And so maybe they would be able to get those services under another funding stream or a contract that the county might have. A lot of the child welfare ECM providers are part of the Full Circle Health Network hub, and so they have contracted with managed care plans, and then they manage all the providers. And so again, they might be able to help kind of navigate, okay, we can't use managed care plan funding for this, but maybe there's another way because the family still needs it. Hopefully that answered your question. Any others? And you can come off mute and ask your question.
I have a question, Baljeet. This is Leslie.
Yes.
You know, as we're thinking about this, right, and thinking about maybe prioritizing, like where do we start, right? It's not always clear to me, so that if you're a child welfare social worker and there's a million things that you're doing, right, and for you to do the ECM referral, my staff want to know, like, what are they going to get out of that, right? And what is the family like concretely going to receive from that referral? And I'm not always clear. Like, I think I'm more clear on kids that really do have medical needs, right? And really need some more like medical care coordination. But for our general foster youth who don't really have, complex medical needs, what do you realistically like see? Like, how should we prioritize those, I guess, referrals? And should we be referring every kid or should there be really some that don't get referred?
Yeah, good question. So, definitely making referrals for your kids with high complex needs, right? So, significant maybe behavioral health needs, obviously for medical needs, maybe folks who also have high social needs like housing, homelessness, right? Those kind of things. Does every child, youth, and family need to be referred to ECM? No, they don't. Because I think sometimes we get too professional heavy. And so, really kind of keeping in mind, is somebody else already providing a similar service? And so, does it make sense to add another provider or professional to that team? Um, so, yeah. And I think, where do you start? Maybe starting with cases as they first come in and kind of working that process out, and then maybe moving on to your FM caseload, your FR, and so forth as you move forward with this. One of the things, like I mentioned, we are, it's fine to refer, but if you don't know what you're referring to or what they're going to do, then it's hard to sell this. And so we are looking at how to help staff understand ECM and the benefits of it and how to provide that training to county staff.
Okay, thank you.
All right, I'm looking at the time, so I'm going to hand it back to Laura to do final comments.
Yes, thank you so much, Baljeet, Corey, and Derek. As we mentioned earlier, we do have our website in the chat that has resources. It will have this video along with the document attached to it. We will go ahead and email the workflow to everybody that registered. It sounds like some of you were having issues accessing the document in the chat, so we will make sure we do that as well. And then just a reminder to that we do have technical assistance available. We have some really strong CalAIM consultants, several that are on this meeting today. And so we are available to help with, referral assessments and protocols, how to strategize and enhance the MCP partnership, and also how to build a training infrastructure with your counties. And so we are a approved vendor on the TA marketplace and can offer some TA services via there. And we also, through a complex care grant that we have consultants that can help as well. Baljeet mentioned several times during today's session that she has met with different counties and different MCP plans to kind of go over ECM and community supports. So we do have that available for you as well. Please reach out. We will put all of our emails in the chat as well. And you can reach out to us if you have any further questions about the document or just about today's meeting in general. And then also, if you can take our quick survey, again, that will help us determine future lunch and learn sessions. These are for you, and so we want to make sure that we're meeting your needs as well. Thank you so much for joining us.